So today what I've decided to do is take 3 cases from the remote past that were good enough to write up and share them with you. And hopefully we can learn at least 3 important facts about infectious disease, and probably many more. So we'll talk about these cases, we'll talk about the diagnosis, and hopefully we'll come to a better understanding. You'll be able to recognize these cases if they occur in your practice. So the first one is entitled Bone Infection and Immunodeficiency. So this is a 59-year-old patient who was admitted to our facility with right distal thigh erythema, edema, and tenderness. 4 days earlier, he reported a low-grade fever to 100.4. He also reported intermittent throbbing headaches for 10 months. He had been diagnosed with DJD 8 months earlier. CT imaging at the time revealed a fracture involving the posterior aspect of the right medial tibial plateau. And a subsequent MRI showed areas of osteolysis on the medial femoral condyle and medial plateau. Now, in the interest of full disclosure, because this was a case that occurred more than 15 years ago, I did not have an X-ray. It wasn't in the publication. So this is an X-ray of a osteolytic lesion of the medial femoral condyle, which you can see right there. It's not necessarily representing the patient, but this is what you would have seen had you been involved with this case, and the accompanying MRI. Now, his past medical history was significant for celiac sprue, diagnosed about 7 years earlier, and hyperplastic polyps. As you all know, celiac disease is an autoimmune inflammatory condition. Those who are affected often have a gluten, are genetically susceptible to gluten, have a gluten enteropathy, has diverse multi-systemic clinical manifestations, and it's synonymous with these terms. So celiac sprue is the major past medical history in this case. So we took a look at the patient, and at the time of presentation, the patient was afebrile with stable vital signs. The patient had some mild stiffness of their neck. Their cardiovascular and respiratory examination was unremarkable, as was their abdomen. But the patient had tenderness, warmth, and erythema in the right knee region with a mild prepatellar bursal effusion. White blood cell count was modestly elevated, and the CD4 count, surprisingly, was 149, or 22%. However, the HIV antibody and the HIV RNA PCR, which at the time we did not have an antigen antibody assay, were both negative. So we looked at this case and we said, this patient has CD4 lymphopenia, but is HIV negative. What are we missing? Any thoughts about things that can cause a CD4 lymphopenia in an HIV negative patient? Anybody have any ideas?
CD4 lymphopenia, malignancy, medications also.
Okay, very good. Very good. So we were basically looking at the differential diagnosis of 2 different clinical manifestations. This chronic headache that the patient reported. So just a recap, throbbing headaches for 10 months, and also this osteolytic lesion of the tibial plateau. So when you think about the differential diagnosis of fever and chronic headache, we want to think about toxoplasmosis, which of course was more of an issue. We saw more cases of toxo in the pre-HART era. Remember that before it was called ART, it was called HART. Before that, it was called, whatever you can find.
I would have called highly effective.
Highly effective, yes. TB meningitis. You might think of fungal meningitis potentially for a cause of low-grade fever and chronic headache. Then you got to think about non-infectious causes like CNS lymphoma, which we often see in CD4 lymphopenic patients, particularly those who are HIV positive. Syphilis, conceivably the great mimicker. Can anybody think of any other conditions that can cause fever and chronic headache?
Parasitic.
So you're thinking about like a parasitosis of the CNS potentially.
With certain eosinophilic things.
Yes. Very good.
Could be.
Okay. I'm trying to think if I, again, you could think of the fact that this patient is CD4 lymphopenic, and so, if you think about conditions that might affect an HIV positive patient with AIDS, probably the differential diagnosis is similar, and I think I've captured most of the major ones in this list. Now, as far as lytic bone lesions, what are the general categories of lytic bone lesions causing a clinical manifestations of this type? Again, I listed bacterial, mycobacteria. We see a lot of patients with chronic osteo, fungal, perhaps. Then primary malignant bone tumors, such as sarcomas, lymphoma. How about an osteoid osteoma? Giant bone cell tumor. Anybody have any other differential? We, of course, also have to think about bone metastases, potentially going to that area.
Multiple myeloma. Is it?
What's that?
Multiple myeloma.
Multiple myeloma potentially causing a lytic bone lesion. That's true. I don't know if there was a extensive sort of skeletal survey in this patient to look for other sources, so maybe this was picked up incidentally because of the complaint. I might also think about some sort of bone trauma, maybe an associated fracture leading to complications including necrosis, perhaps due to ischemic issues. Okay, so let's see what everybody thinks in terms of the general categories of infection. Because we are infectious disease clinicians. So how many of you are banking on a bacterial process? This did turn out to be an infection, by the way. It was not a tumor. So if you believe it's bacterial, raise your hand. Okay. How about mycobacterial? Anybody want to go for mycobacterial?
Could be TB.
Okay. General category of fungal. Anybody fungal, perhaps? See a couple of people. Okay. So fungal causes of a of a lytic lesion, of a bone infection. Anybody want to call out a bone infection that could cause blastomycosis? That's an excellent thought. Crypto, indeed. Anybody else? How about anybody with histo? Maybe cocci?
Yeah, with the low CD4 crypto, I think.
And could there be a CNS component because the patient did present with a chronic headache, right? So let's see what happened then. So the patient was taken for LP exam. There was a predominance of lymphocytes. The CSF fungal culture was positive for Cryptococcus neoformans. The CSF cryptoantigen test was 1 to 1024. The patient received a bone biopsy of the right tibia, and the results showed necrotizing granulomatous inflammation with yeast organisms. So a diagnosis of cryptococcal meningitis with skeletal dissemination was made. So if you look here on the photomicrograph on the right, you can see the numerous yeast with variable shape and a narrow neck budding consistent with Cryptococcus species. This is in a GMS stain. The publication just had a black and white photograph. I went back in my archives and I found the color one. I'm so happy I did because it displays that beautifully. So this turned out to be cryptococcal meningitis with skeletal dissemination. So we know the patient is CD4 lymphopenic, right? But the next question is, what made this patient susceptible to cryptococcal meningitis with skeletal dissemination? So we'll answer that in just a second, but how do we manage this patient? So The patient initially received amphotericin B deoxycholate, which I don't even know that we even have anymore, but again, this was some years ago. And the patient was switched to liposomal amphotericin B on day 8 due to nephrotoxicity. Induction treatment was given for 4 weeks. The post 4-week LP showed clearance of the organisms from the CSF and a decrease in the cryptococcal antigen titer to 1 to 32. And the patient reported that the distal tibial swelling and discomfort nearly resolved, and at that time the patient was switched to oral fluconazole 400 milligrams per day. Now, unfortunately, 7 weeks after treatment initiation, the patient was readmitted with a relapse. There was no evidence of knee exacerbation of the prior symptoms, however. So the knee was better, but the patient had a relapse in the meningitis. The patient was reinduced for 6 weeks and then de-escalated to oral voriconazole for indefinite suppression. So to reiterate the specifics of this case, the patient was HIV negative but had unexplained CD4 lymphopenia, right? The patient had no prior history of opportunistic infections or immunosuppressed status, and no known risk factors for cryptococcal exposure that he identified. So kind of weird. Any other thoughts about this case at this point? How many of you have seen patients with CD4 lymphopenia that you can't explain? Yeah, it happens, right? So
one question I had, he recurred after 7 weeks or so, 8 weeks, once off therapy?
yes. I think he was on fluconazole.
So he was still on fluconazole?
Yes.
Because you have to ask yourself, do you treat this like an HIV, like an AIDS patient where you chronically suppress them,
Mm-hmm.
or CDC4 count goes above a certain number? Right?
Yeah, and that's a really good point. And I don't know, this case happened maybe 15 years ago, and I don't know if the thought process was as much there. Perhaps it was, but we did struggle with those issues when the patient was treated.
There's no guidelines for non-HIV patients with low CD4 counts, but I would, I tend to treat them as if they were and then follow their CD4 count. But there's nothing that says you should do that.
Yeah.
Yeah, I had a case with the about the CD4 lymphopenia, but the CD4 was like 8, 9, something like that. He presented with disseminated MAC.
Mm-hmm.
And when I go to pseudo literature, normally this patient presents with cryptomeningitis is the first presentation.
Yeah. So, so again, to answer the question why he developed disseminated cryptococcus, again, noting that the patient had a diagnosis of celiac sprue, he was taken for EGD following hospitalization. And the EGD results showed numerous lymphangectasias throughout the small bowel. And you can see the small bowel biopsy here, showing dilated lymphatic channels consistent with the diagnosis of lymphangectasias. No other pathological abnormalities were present. So medical records indicated that the 7-year-old diagnosis of celiac sprue was clinical and not biopsy proven. And because he was noted to have lymphopenia peripherally, this is not associated with celiac sprue. So as Carlos said, he was presumed to have become lymphopenic via a protein-losing enteropathy. Pretty interesting, right? So this was a diagnosis of...
Yeah,
That's what you guys in the end kind of thought.
So we don't know what came first, but he had the biopsy on the small bowel, it grew a MAC that was causing protein-losing enteropathy. So we don't know if the chicken or the egg came first. We don't know.
So this was a case of intestinal lymphangectasia. And intestinal lymphangectasia is a poorly recognized cause of T-cell deficiency, and it can be due to primary ectasia of enteric lymphatics or due to secondary factors, including cardiac disease, infection, or chemotherapy, which can cause a loss of lymph with leakage of immunoglobulins and or lymphocytes into the gut. It was first described by Waldman in 1961. Although it primarily affects small children, it may first manifest itself well into adulthood. And in addition to cryptococcal infection, case reports have documented episodes of cutaneous warts and lymphoma as well. So Osteomyelitis incidence in disseminated crypto is less common. It's about 10%, but this patient did develop it. What's interesting is usually it occurs in the vertebral spine, not necessarily in the long bones. And debridement and systemic therapy provides the best outcome. So again, intestinal lymphangectasia may be an unrecognized cause of significant number of cases of invasive cryptococcal disease in patients with idiopathic CD4 lymphopenia in which no other source of immunodeficiency has been identified. And maybe some of you were aware of that, but we were totally blown away when we saw this case because, you know, how many of us think, well, this patient's lymphopenic from loss of lymphocytes and immune factors in the gut, but it can occur. And so if you see one of these patients with idiopathic CD4 T-cell lymphopenia, I would strongly suggest you consider this case. Or if you see someone with an unexplained course of Cryptococcus or another opportunistic infection with some T-cell lymphopenia. Yes, Carlos?
Like a chronic diarrhea?
I don't believe that was documented in the case, and to be quite honest, because this case occurred a long time ago, I don't recall. But again, he was diagnosed with sprue, so he probably had some of the symptoms of sprue. So.
Because you suspect you have to order alpha-1 trypsin on the stools 24 hours to see if he was losing like a lot of proteins. That's the only way. Or a biopsy, huh?
And one of the frustrating things about writing up a case many years ago is you lose track of the patient. So I don't recall this patient's identifiers because this case was published in 2005. And so I can't look up how the patient's doing, but I have to rely on what's in the write-up, unfortunately. But so again, this was a case we published in 2007 from a patient in 2006. All right, so we're just getting warmed up. Let's go on to the next case. So this case is called lower extremity cellulitis and bacteremia. This was a 49-year-old homeless man. He became despondent and jumped from a bridge into a freshwater canal in Central Florida in early July. And he developed swelling of the left distal leg 12 hours after the incident. I'm glad I can present this case because it was in July and we're in July, so we can think about the differential of aquatic cellulitis in July. There was a subsequent onset of increasing erythema and warmth to the area, and he presented to the emergency department 72 hours after the incident. So what are we thinking about to begin with? Aquatic cellulitis, jumping into a freshwater canal. We have Vibrio vulnificus, right? Potentially Eromonas, very good. So.
Freshwater.
Yeah, is it real freshwater or is it?
Well, it was described as a freshwater canal, but again, a lot in Florida because we're so close to the sea, you know, to the Gulf. A lot of times, freshwater could be brackish, right?
Tell me the location. I'll look it up.
The canal behind your home.
Yeah. Well, then he ain't got any water going. I don't have any. Unless it's rainwater. I have a gator bite.
So this is a moderately obese white male, no acute distress at the time, but he did have a fever of 101, a pulse of 98, a little bit borderline tachycardic. No regional or generalized lymphadenopathy noted. Lungs clear. He had some spider angioma in his upper chest, consistent with chronic liver disease, palpable liver margin, no fluid wave. And on the left lower extremity, he had some modeling of the skin of the left anterior tibia with mild erythema and warmth, no hemorrhagic bullae, minimal tenderness, and no sensory anesthesia. So he was not like in acute distress, but he did have a cellulitis there. And how many people, raise your hand, you think this is Vibrio vulnificus? I mean, it's okay to put it out there, okay. Yeah, and it could, yeah, and I,
It's a zebra talk.
Yeah.
this case,
That's
you guys are too good. I could have given you too easy of a case.
I mean, this would be the usual things you think of. However, there are some other.
It's Vibrio, so prove another one.
When I was a fellow, they had a guy, these two guys were out fishing, and it was off of some pier.
You mean fishing?
Fishing.
If you're real
Somebody
fisherman, you
looked-
got to
I
leave the
don't
G off.
remember what the fish was, but it was quite large. So his friend was going to jump in the water to help him, and his friend jumped in the water. The dorsal fin was up on this thing, and his foot went straight through. So they transported him to Tampa General with the fish still stuck in his foot because they're afraid to pull it out. They presented that one in Morning Report. There was not a dry eye in there. People were like, oh my God.
So what did it turn out to be?
It was, why am I blanking now?
He had the barb from the fish in there? Is that what
I
you're
hit the whole fish attached to it, but yeah, the fin from the fish had gone through his foot, completely through his foot.
Very simple.
Yeah, they were simple first.
Did they have the fish in like a little tub of water? You know, you don't want the fish to like, you know, hopefully you can catch it and you can release the fish. All right, well, so here's laboratory studies for the case. White blood cell count is 5, hemoglobin 12.7. Little sort of borderline thrombocytopenic, platelets 118,000. Renal function was normal. Transaminases are shown there. Blood cultures became positive after 48 hours for an oxidase positive, non-lactose fermenting gram-negative rod in both aerobic bottles. The lab was unable to identify the strain.
Always a bad news.
So the plates were sent out to Quest Diagnostics for further testing. So for those of you who are biochemically savvy with your gram-negative organisms, does this limit your differential somewhat?
So the positive could be Pseudoaneurysm, is that one?
Yes.
But you would think they could grow that.
How about, does this change your differential for Vibrio vulnificus?
It could still be good, right?
Yeah, it could-
Now that is true.
Depends if you're here.
yeah.
That is true. It still can be Vibrio vulnificus, but about 85% of Vibrio vulnificus are lactose fermenting. 15% are not. So does that alter your opinion somewhat? Vibrio, of course, is oxidase positive. So
Usually they can give you a genus.
mhm.
They may not get a species. So I don't know.
Okay. Well, here's what was done before we get to the diagnosis. Empiric therapy was started with unison and levofloxacin. Repeat blood cultures were documented as negative at 48 hours. Patient was transitioned to oral levo and IV antibiotics were discontinued. Lower extremity erythema rapidly improved with antibiotic therapy. Patient was discharged on hospital day 4 to complete a 14-day course of levofloxacin. So fortunately, this is a case that responded, right? If you're talking about an aquatic associated cellulitis, a lot of fear, Vibrio vulnificus, necrotizing infection. And so fortunately, the patient responded to treatment.
Aromonas is oxidase fits that description.
So
Everything in fresh water,
yeah, so but mainly
lactose fermenter.
Yeah.
so aerobic non-lactose fermenting oxidase positive gram-negative rods. Think about Pseudomonas, Burkholderia, perhaps Aromonas.
Yeah, that was the other one, that guy that we got from Puerto Rico, we ended up with Burkholderia. That they got it to Burkholderia, but they couldn't get it any further, and they had to send it to CDC.
Mm-hmm.
And that's when it came back with Pseudoaneurysm.
Yeah. So the organism was tested and was found to be susceptible to amikacin, ampicillin, cefazolin, piperacillin, tobramycin, and Bactrim. However, Burkholderia and Pseudomonas are not, of course, susceptible to first-generation cephalosporins. And Vibrio vulnificus, of course, generally susceptible to most antimicrobials in vitro. Vibrio parahemolyticus, many strains are resistant to ampicillin, incidentally. So that's the one that tends to be a bit more resistant. So how many people think this is Vibrio? Raise your hand. Burkholderia, Eromonas,
I'm still intrigued why they can't get it to genes.
Okay, so let's talk about our differential diagnosis of aquatic cellulitis. So if you're thinking fresh water, then the differential, of course, is Burkholderia, Eromonas, among the Mycobacteria, M. fortuitum. Let's not forget Plesiomonas, which is generally associated with brackish water, but can also be seen in fresh water. Pseudomonas, and also Streptococcus ineae. So for brackish water, think about Chromobacterium violaceum, Eromonas, Edwardsiella, Plesiomonas, and Streptococcus ineae. Now our saltwater pathogens, Erysipelathrix, M. fortuitum, M. marinum, Shewanella species, and Vibrio vulnificus. And of course, we've had a bunch of cases of Vibrio vulnificus in and around the state of Florida this summer so far, usually associated with very warm ocean temperatures, close to 90 degrees. Higher the temperature, generally speaking, the more cases. So you can debate the pros and cons of whether the media is kind of, sort of scaring the public with flesh-eating bacteria and doing, perhaps some harm in addition to increasing awareness, which is good, because people are. I mean, I had somebody ask me the other day, a young person, should I go in the ocean because I'm going to get this flesh-eating bacteria? And of course, I said, if you're not immunocompromised, you don't have liver disease, you don't have a reason to be susceptible, then going in the ocean is safe. So, relatively speaking, if you can avoid the sharks.
Yeah, I was going to say, don't step on a skate.
Yeah. All right. So let's see what happened. Okay. So via 16S RNA DNA or ribosomal DNA sequencing, the organism was identified by Quest as Herbaspirillum ceropodicae.
See, I knew it. It's going to be something really odd.
Antimicrobial sensitivities, of course, as we said before, MICs were not available. So how many people have heard of Herbaspirillum? I guess I should say Herbaspirillum. This was Herbaspirillum species, or Herbaspirillum ceropodicae.
That would be something you put on.
Is that our name? Is that our name for that?
On the answer.
No, that's it.
On the board exam, just to throw people off.
Well, I'm sure.
Because everyone would be like, nah.
Yeah.
It's not
Isn't that a
that.
marinade for steaks? Really? Just put the steak to marinade.
From the
Herbaspirillum.
family of
So this is actually within the order of Burkholderialis. It's as we said, an aerobic non-lactose fermenting oxidase positive motile gram-negative rod. Herbaspirillum species encompass multiple organisms, primarily nitrogen-fixing bacteria associated with plant roots, stems, and root nodules, but do not survive in soil. It's rarely implicated in human disease, and sometimes it's cultured from the wounds, eyes, and respiratory secretions of cystic fibrosis patients. So we believe our 2005 case to be the first reported case of Herbaspirillum bacteremia in a human. The suspected risk factor was hepatic cirrhosis, and fortunately the bacteremia quickly cleared within 14 days with antibiotic therapy. Other aquatic pathogens are more aggressive and hard to eradicate, such as Vibrio vulnificus and Eromonas. So for the patient, this was actually fortuitous because he happened to become bacteremic with a bacteria that was pretty responsive to antimicrobial therapy and quite susceptible to most antibiotic agents. So what are our
CLS like breakpoints for this?
Yeah, well, that is a good question.
Yeah.
So what are our conclusions? What do we take from this? With a presentation similar to other waterborne pathogens, we feel that Herbaspirillum should be recognized in the differential diagnosis of cellulitis with or without bacteremia in a patient with freshwater exposure. It's possible because of the difficulty in biochemical evaluation, the need for rDNA sequencing analysis, other cases of Herbaspirillum species associated human infection may have previously been overlooked. And we don't know, this is 15 years ago, we don't know if nowadays they would use maybe Molotov to identify this, this pathogen versus previous methods of sequencing analysis. Recognition of the pathogenic potential of this largely uncharacterized organism will ultimately permit a greater understanding of the spectrum of Herbaspirillum species and its clinical effects on humans. So think about Herbaspirillum, cellulitis in your differential of freshwater cellulitis. And this was published in 2005. So.
Did Tan make the diagnosis?
Well, he was, Michael Tan was one of our fellows at the time. Now he's a very distinguished clinician who works with Thomas File and in the Summa Health System in Akron, Ohio. But he is a great clinician. I hope we can have him down for a talk one of these days.
Whenever there's a run over in Disney.
Yes, whenever he comes down for Disney. He's quite a Disney file. All right, so our ultimate case is, and we have a few minutes here, is this one. It's our third and final case. So now that we've had a chance to really get our differential diagnosis hats on and our creative juices flowing, we can think about what's going on here. All right, so this is a 50-year-old African-American male who was seen in the ED. I think this case was published in the late 2000s. Seen in the ED with acute fever, nausea, vomiting, diarrhea, right lower extremity tenderness, and numbness. He reported pain in his right lateral upper leg with paresthesias below the knee. That morning, the patient had awakened to notice local discomfort and swelling in his right lateral tibial area. So again, a patient with constitutional symptoms, pain in his right lateral upper leg, paresthesias, and right lateral tibial area discomfort. That's our presenting symptoms. This patient had a past medical history significant for lupus with renal and cerebral vascular involvement. He was steroid dependent. Sorry if I didn't put the dose. He had sickle cell trait, he had anemia, and he had heart failure with reduced ejection fraction, EF of 25 to 30%. Past surgical history was significant for a AAA repair in 1993 and a right axillofemoral bypass and thrombectomy in 2000. He is a non-smoker, non-drinker, and he's married for a social history. He denied any specific environmental or dietary exposures, but let me say parenthetically, a lot of times when I see patients, maybe you all have the same observation, and I say, well, you know, have you eaten anything unusual or have you been anywhere unusual? They'll say no. Should you stop there? No, a lot of times you need to question, well, have you eaten any restaurants you don't normally eat? Did you eat any you really need to get into the history with them. So, but this was his initial denial. So when further questioned, he recalled visiting a fast food Mexican restaurant and eating a burrito on the previous day. Now I'm not going to tell you which fast food restaurant this was, but I'll just say that if you really think about it, it should ring a bell. It should ring a bell. I'll stop there.
I was going to find the logo. Yes, we actually call it taco smell.
So he also recalls dining at another fast food chicken restaurant, and he mostly had reported hot meals prepared at home by his family members. He said he avoided cold foods and dairy products. So when we saw him, he was a cachectic 50-year-old African-American male on a gurney. Fever was 101.3. He was a little hypotensive and tachycardic. He had no CNS signs. Lungs were clear. Cardiovascular examination was regular rate rhythm with no murmurs. Abdominal examination was benign. He had a left AKA, so again, signs of peripheral vascular disease, right? His right lower extremity had some modeling of the right foot and coolness of the foot to the ankle level. He had decreased sensation below the knee with weakness of the entire right lower extremity, particularly distally. And I'm sorry I did not publish the photo in this case report, so I don't have that to show you. White blood cell count was 7,000. Hemoglobin, he was anemic, hemoglobin of 8.7. He had some hyponatremia, sodium of 132. Creatinine was 1.5. Normal transaminases, alkaline phosphatase was 166. His INR was 1.45. And chest X-ray showed no acute process.
The creatinine is his baseline, or is this AKI and chronic?
I believe this was AKI.
Because you said his SLE affected his kidney returns.
Yes.
But
So maybe there's an element of chronicity here, but I don't think that he had severe renal insufficiency. Probably just moderate impairment. So, patient was emergently taken to the OR, again with these symptoms in the right lower extremity, his history of peripheral vascular disease, and he was found to have an occluded axillobifemoral bypass graft. So the vascular surgeons performed a thrombectomy with revision of the right femoral anastomosis and a right calf fasciotomy. He was also found to have a pseudoaneurysm of the ascending aorta with a residual thrombus by perioperative thoracic CT. Graft material submitted for histopathology showed rare gram-negative cocci. So what do you think about when you think of rare gram-negative cocci? Anybody, any thoughts? So,
if you want to put
Some-
the little
some-
eating rest-
so you think maybe salmonella, maybe yeah, maybe staph. Maybe you could think of staph that's misidentified potentially. But when we saw that at the time, we were a bit puzzled by it. So, rare gram-negative cocci.
That's a good thought with the food, with the Taco Bell.
So let's think about the differential diagnosis of gram-negative cocci further. So when we talk about diplococci, it's usually a Neisseria. So could this be a case of Neisseria, various species? You can think in your mind what would cause graft involvement. Maybe Moraxella acinetobacter with some different initial morphology. Maybe a gram-positive cocci with a falsely performed gram stain. Rarely others, such as gram-variable strains. Anybody have any other thoughts? And how about the differential diagnosis of acute lower extremity graft thrombosis? So this patient presents with a thrombosed graft and a fever. Maybe arterial trauma. Some of our patients experience trauma, let's say getting in and out of a mobility device or maybe having a fall. That wasn't really reported in this case, but something to think about. Acute aortic or arterial dissection. Maybe think about that. Arteritis with thrombosis. Spontaneous thrombosis associated with hypercoagulable states. This patient's INR was a little elevated, in fact, however. How about some local compressive physiology like popliteal cysts or entrapment, vasospasm. But you also have to think about a septic thrombophlebitis, particularly in a patient who presents with fever, right? So, any thoughts? Let's focus specifically on his foodborne exposures. Patient reports some foodborne exposures, said he ate a burrito, ate at a fast food chicken restaurant as well. Any thoughts about pathogens that can include a graft? Again, you mentioned salmonella potentially.
Staph, bacillus, Clostridium.
Okay.
And anytime you mention gram-variable rods, or gram-variable organisms, you can think of Clostridium too.
Mm-hmm.
I think before, this is because we have a blood culture, right? Or most of the time we don't have that. So the way to approach it is also, he has multiple sites, right? He had developed an acute thrombosis on the lower extremity, plus he has this new pseudoaneurysm up high too. So you have to think of a more systemic process that could affect multiple sites. Right?
All right.
Because you're not always you may not have the blood culture right away, so you got to think of what can do that.
So, so following the OR visit, blood cultures obtained at admission became positive for Listeria monocytogenes and coagulase negative staphylococci in 2 out of 2 sets. Unfortunately, graft material cultures were not obtained by the surgery team. But how many times have we seen that happen, unfortunately? Sometimes our surgeons don't help us with cultures. Yes.
See what I mean? And that's because no one's thinking, there's no blood culture yet, so nobody's thinking about how this could have happened in multiple locations. I mean, yeah, you could have a pro-clotting state that could potentially exist, especially in a patient with SLE and vasculitis. But I mean, the most likely thing is an infection. So if you're not thinking about that going into it, you're not going to send the culture.
And you know, and the association with
I mean, it's Taco Bell. It could be anything.
with Listeria in this case really kind of blew our minds because you know, Listeria causing graft thrombosis and a pseudoaneurysm. It's like whoa, but yeah, that was the interesting facet of the case. Postoperatively, the patient was started on Vanco, ampicillin, and Gent. Coronary arteriogram performed on the 10th postoperative day further identified the aortic root pseudoaneurysm with associated involvement of the left main and proximal coronary artery. Surgical intervention, however, was deferred due to the high risk of the procedure. So let's talk a little bit about Listeria monocytogenes. It's a non-sporulating, facultatively anaerobic, catalase positive, oxidase negative, gram-positive rod that displays beta hemolysis. In clinical specimens, however, surprise, it can appear gram variable and resemble diphtheroids cocci or diplococci. In clinic, it's an increasing cause of disease in several high-risk groups. We particularly think about expectant mothers, right? Pregnant women, but also neonates, the elderly, transplant recipients, and those who have both innate and acquired cell-mediated immune disorders. It's the only Listeria species that affects humans. And there's been, if you look at the CDC website for Listeria outbreaks, you will find an amazing spectrum of food products, from soft cheeses to raw milk. You know, there's a big thing right now with raw milk. How many people have heard of people who go to local dairies and get raw milk? Huge thing, right? Is it a good idea? No. For this and other reasons. Deli sliced meats, frozen vegetables, packaged salads. So not only can you find a bat in your bag of packaged salads, how many people have heard about the bat? We talked about it in one of my previous presentations. Lizards and toads and all sorts of things. Bean sprouts can be associated with listeriosis. There's many others. But the one that maybe we remember about from earlier in this decade was the Listeria outbreak associated with Bluebell ice cream that caused multiple cases of listeriosis, serious illnesses from 2010 through 2015, linked to 2 Bluebell production facilities in Alabama and Texas. They went out to these factories and they found leaky roofs over vats of ice cream mix, poor cleanliness in those factories, and a little attention to preserving the cleanliness of the product, leading to these outbreaks and the removal of Bluebell ice cream from store shelves for a long period of time. I think it was more than a year. If you go to your local grocery store now, you'll find Bluebell ice cream back in the shelves. But this was a huge outbreak and sort of a wake up to the public. If you want to learn more about it, the link is there. So
one memorable thing about that outbreak for me, I was just starting here to work here as an attending when that Listeria outbreak was going on, and I had been reading about it. And then I go to SCI, and there was free Bluebell ice cream given to all the SCI patients.
That's
Coincidentally.
So we could get our
I was like,
reviews
no,
up.
get this out of here. But anyways, so I'll never forget because of
Yes,
that.
because I remember you coming up and telling us all. We may be busy.
But the reason why you think about listeriosis with ice cream and other products is it grows preferentially to other bacteria at refrigerator temperatures from 4 to 10 degrees Celsius. And Listeria can cause a variety of different conditions. Sepsis, osteomyelitis, liver abscess, and cholecystitis were case reports that I found. CNS disease, of course, is most well known. Meningitis, meningoencephalitis, brain abscess, endophthalmitis. Vascular infections with Listeria are rare, but then they can occur. We actually did a retrospective in our article of 18 cases found in the literature up to that time. Endocarditis has also been reported with Listeria, so keep that in your differential. Mycotic arterial aneurysms are also rare. Most of them occur due to seeding following an episode of bacteremia. Yes?
As you mentioned, the term that was always thrown about is it's called cold enrichment, that they grow much better in a colder environment than they do if you put them into an incubator. The other one that you'll probably never hear again is that if you do a hanging drop, we have a drop of fluid and put Listeria in, it has tumbling motility. It is a motobacteria.
Yeah. So this was in our article, comparison of Listeria infections versus Listeria endocarditis over the years. What we found was the arterial infections tended to involve older patients. Endocarditis, on the average, tend to involve the younger patients. You can look at mortality rates there. The presence of a prosthetic valve was a significant risk factor for the development of endocarditis. And positive blood cultures, the incidence in arterial infections about 28%. So now how about this aortic root pseudoaneurysm that the patient had? There was strong circumstantial evidence pointing to the development of it with the onset of his listeriosis. Risk factors included his chronic steroid use and lupus. A TE that the patient had 15 months earlier did not show the aneurysm. Unfortunately, no cultures were collected of the ascending aorta, and the gram-negative coccycine in the tissue specimens was felt to be Listeria organisms with atypical morphology.
They're still calling them.
So mean age of arterial infection, 65 years. 89% of cases were in patients 50 years and older. Risk factors are shown there. Risk factor for endocarditis, as I said, prosthetic valve. A third were associated with vascular grafts. The mortality was about 33%. Now, how about antimicrobial management? As you all know, ampicillin is acknowledged to be the antibiotic agent of choice. For serious infections, gentamicin is often added. For penicillin allergic patients, consider Bactrim. Septra can be used in combination with ampicillin if you have a patient, for example, who's not a good candidate for an aminoglycoside. Other active agents, meropenem, linezolid, cephalosporins, of course, are not active, and most vascular infections are treated for a 6-week course. So what happened to the patient? Well, following his thrombectomy, the patient completed a 6-week course of Vanco for the coag-negative staph that was also found, plus ampicillin and an LTAC. 6 weeks post-treatment, negative blood cultures were documented and his vascular implants were felt to be stable. Fortunately, within 4 months of his original diagnosis, his pseudoaneurysm, which could not be surgically corrected, began to enlarge, and the patient developed an obstructive left mainstem bronchus from compression of the aneurysm. He ultimately died from a post-obstructive pneumonia. So, Dr. Gompf was also on this paper too. Dr. Gompf, you may remember this case with the good Dr. Elko, is one of our former fellows. So, here's our summary. Yes, Dr. Vega, before I go over that.
I just wanted to bring up, I think a lot of us physicians kind of forget about some of the most important parts of what we do, which, in my opinion, there's so many patients that we put on chronic steroids or other people put on chronic steroids, and I don't think we do a good job at counseling them as to, what things to stay away from and to be more conscientious of. And the risk of Listeria is very well known on people on chronic steroids, cell-mediated immunity, right? So just like we advise pregnant ladies to not eat stuffed cheeses or not deadly foods or whatever, we should probably be doing a better job advising everyone that's on chronic steroids or with cell-mediated immunity. Is not as common, but it's certainly a possibility, and we've seen it a lot of times. And then the other thing is, once you throw some graft material into anyone, disaster will ensue if they have any kind of bacteria. But yeah, just the counseling part, the trying to prevent things is what we should be focusing on, because then they end up never being surgical candidates. And after that, we just can't fix it. So.
Yeah. So from being involved with this case, I always think about Listeria in graft thrombosis, and also I think it emphasizes the importance of getting a history of exposures in patients like this, because that was an important facet of the case. So think about Listeria monocytogenes in a patient with these risk factors, including the use of chronic steroids. And in fact, he was immunocompromised from that, and also his lupus. But so, in summary, what did we learn today? So, intestinal lymphangectasia, think about it as a possible cause of T-cell deficiency, CD4 lymphopenia in HIV-negative patients, and also in those in whom opportunistic infections occur, including cryptococcosis. Think about Herbaspirillum species in the differential diagnosis of an aquatic cellulitis in patients with exposure to plant material or moist freshwater soils, particularly at this time of year. And lastly, think about Listeria as an acute febrile illness in patients with risk factors and compatible foodborne exposures. Graft infection and arterial thrombosis can occur secondary to associated bacteremia, and also think about the possibility of Listeria endocarditis occurring in younger individuals. And that is all. Thank you all very much.